So why don't we start with this, guys? It would be great to revisit the discussion from March. Obviously, things are evolving as it relates to treatments of carotid disease. I think most importantly, when we last talked, there was some momentum toward reimbursement, but also some changes in the way technology platforms are evolving. Endovascular solutions seem to be beginning to catch momentum after a number of years of some stagnation. So maybe just take a couple of minutes and give your perspectives of what you're seeing and hearing, and of course on the back of the VEITH Symposium where the most current data and technology is being presented.
I'll be happy to start. So I think since then we continue to see, Sean and I have been honored to be on a multi-society carotid alliance. The idea is getting all specialties together and petitioning CMS for what really should have been done years ago, that this should be reimbursed. And we've seen that they've already acted for TCAR, for getting standard low-risk patients approved for that. And I think now, even since our last meeting, there's been more evidence that comes out that just suggests we're there now. We have a SPACE-2 and we have ACST2, both again showing equivalency of carotid stenting to carotid endarterectomy, which, as we all know, has been reimbursed for a long time. So you couple now five randomized trials showing equivalency, long-term data, 10-year CREST that shows that they're both outstanding, endarterectomy and stenting. ACT-1, 5-year, outstanding. ACST2, 5 years, equivalency, outstanding. Couple that with 50 or 60,000 registry carefully adjudicated patients. I think that now the consensus is they asked us to put a paper in JACC, a white paper, together with the state of the art of carotid stenting, which several of us were on that paper. That's been published just like they asked. So I think we're in a good spot. In fact, I personally don't see how they could not approve a technology with so much data in favor of it. So I think we're in a good spot, and a lot of us have waited a long time for this, some even longer than others. So great. That would be Chris's take.
So before Dr. Lydon answers, just wanted to quickly introduce the late member to the crew here, but an important part of our KOL board and group, Dr. Kenny Rosenfield from Mass General, who's joining us today. So we're, again, trying to expand the original group to get different perspectives. One of the things that we love about being able to put this multidisciplinary group together is the focus on carotids obviously goes way beyond one subspecialty. So we're really thrilled to have a really diverse group, both internationally as well as subspecialty. So the question, Dr. Rosenfield, was, from our last KOL discussion, what have you observed? What's changing? Obviously, the carotid space is moving forward in a lot of different ways. And I just wanted a general idea of your perspectives, especially on the heels of the VEITH Symposium and the latest data.
So, I would agree with Chris. We were able to put out a white paper that shows we have a pretty good idea of a lesion that might be treated surgically, might be treated with TCAR, might be treated transfemoral, or it might be treated well with all three modalities. And so really the official submission is in to CMS to ask them to reconsider the NCD. And really it's to try and put this therapy back in physicians' hands. So we know that carotid therapy works, whether it's surgery or stenting, whether it's transfemoral or transcarotid. We know through 10 years, the data shows are equivalent therapies. Nobody concerns anymore of the durability of carotid stents. We've proven they can all be done safely. And it's really the ask to CMS is to say to let physicians decide how best to use it, to have informed discussions with the patient, medical management versus all the options, and then really to customize it based on local expertise, training, and just like every other thing we do in medicine, to have how it's adjudicated, how it's credentialed up to the hospital credentialing committee. And, those hospital credentialing committees tend to use societal guidelines in terms of how someone becomes credentialed to do this. And I think we've really seen, from that white paper putting out there, just a summary of where the data set is. If we look at the last time the NCD was looked at back in 2009 and 2010, the big ask that CMS said was there was no late data. And now there is an abundance of late data. And along that lines, we've seen TCAR, using the VQI data show that in low risk patients, it's done very well, despite the fact the registry was supposed to be high risk patients. And now seeing the broadening of coverage to do it. So I think, we're seeing investment in the space. We're seeing, besides what we're seeing with Inspire MD, there's Contigo Medical having new devices. And I think there's a lot more interest because, finally, I will not have to have the awkward discussion to a patient of what I think's best, as opposed to looking down to see what their insurance is. And I can just do what I feel is appropriate for the patients.